So I'm going to introduce Steffie's introducer, and that is my fellow PNHP New York Metro board member, Will Ford. Will is a third-year med student at Weill Cornell Medical College. He's leader of Weill Cornell's chapter of Students for a National Health Program, as well as a student board member of our PNHP New York Metro chapter. Will, take it away.
Thanks so much, Martha, for that introduction. And thank you again to everyone who's tuning in tonight for our forum. We're really glad that you could join us for this exciting event. So I'm delighted to introduce our next speaker, Dr. Steffie Woolhandler. Dr. Woolhandler is a co-founder of PNHP and a practicing primary care physician. She's also a distinguished professor of public health and health policy at CUNY School of Public Health at Hunter College. She's an adjunct clinical professor at Albert Einstein College of Medicine and a lecturer in medicine at Harvard Medical School. She's the co-author or author of many relevant peer-reviewed research articles on single-payer healthcare. And most recently, she's published articles co-authored with PNHP co-founder Dr. David Himmelstein and PNHP president Dr. Adam Gaffney about the dangers of our privatized multi-payer health insurance regime in the intersecting crises of the COVID-19 pandemic and its resulting economic downturn. Dr. Woolhandler, thank you so much for joining us tonight.
Hey, well, it's my pleasure. I don't have any financial conflicts of interest. I do, I guess, have other conflicts. I actually was an unpaid campaign advisor for the Sanders campaign, as well as having a close professional relationship with Elizabeth Warren. Okay, let's see. I can't get my screen to advance here, so maybe the PNHP folks are going to have to do that for me. Okay, I'm viewing Will Ford's screen, so that sounds right. Okay, probably most people on the call are well aware of the very high death rates from COVID-19 in the United States, and that these vastly exceed death rates in other countries. Next. You're probably also aware that the pandemic has been much more serious and lethal toward Black and Latinx people. These are the numbers for New York City as of 3 days ago, but this is being replicated around the country. Next. Okay, now why was the United States so vulnerable to COVID-19? I'm going to talk about 4 different reasons. There's the fact that the health status of the American people has been deteriorating since about 1980, but particularly over the last few years. We have a weakened public health capacity. We have a crumbling and racist social safety net. And we have a wasteful and I would say structurally racist healthcare system that prioritizes profitability over needs and discriminates against all poor people, but particularly poor people of color. Next. So deteriorating health status. Here I've graphed life expectancy in the United States and several other nations, and you'll see through the 60s and 80s, the US was pretty much middle of the pack in red, but since about 1980, the United States has been falling off the curve. And actually, in 3 of the last 4 years, life expectancy actually fell, and almost certainly life expectancy is going to fall again in 2020. Next. So on top of this poor underlying health status, we have the problem of public health being relatively defunded. Public health has fallen as a share of total health spending and is now only is under 2.5% of total health spending versus about 6.2% in Canada. So we're not getting the health dollars to public health. Next slide. Now Trump has further weakened public health in several ways. He's demoralized the public health workforce. First of all, there was a hiring freeze in 2017, during which there were 700 positions at the CDC that were left vacant. In 1918, Trump abolished the Global Health Security Team to the National Security Panel, effectively demoting pandemic preparedness experts. 1,600 government scientists have left positions since Trump came into office through this demoralization. And many key science positions, including the OSHA administrator, have been left vacant. Recently, Trump defunded the WHO, which is responsible for global surveillance and risk mitigation, which we're going to need if we're ever going to get out of this pandemic. And then obviously 2 days ago, he announced that he told his people to do less testing to make his numbers look better. So a lot of actual weakening of the system, but also demoralization of folks who are tasked with defending us against pandemics. Next slide. Okay, so the frontline healthcare workforce, that is the people at local health departments who do contact tracing, who keep track of the rates of disease. In some cases, they do lab testing. The frontline public health workforce has declined by 20% over the past decade and a half. Next. And of course, I do believe, like Richard Horton, the editor of The Lancet, the defunding of the World Health Organization is actually a crime against humanity, likely to harm health of people in the United States and around the globe. Next. But what about the social safety net? What are the issues there? And again, I think many in the room are familiar with this, but in New York City, we have 400,000 children who live in poverty, and there's 114,000 students in New York City public schools who were homeless in the last year. So profound impoverishment of part of our population. Next. And of course, housing has remained a major issue, and its social distancing is impossible in homeless shelters, but in fact, extremely difficult in the crowded circumstances in which many poor New Yorkers and poor people in the United States generally are forced to live. Next. And within our prison and jail system, which houses about 2.2 million Americans, again, social distancing and protection from contagion is virtually impossible. And just to read you the headline, these are folks at Rikers who are going out to dig mass graves for New York City coronavirus victims. Next slide. Okay, so what about the failing healthcare system? Next, I think people are more familiar with that in this group, but the number of uninsured has almost certainly shot up since the beginning of the COVID epidemic. There's likely about 43 million uninsured Americans as of the end of June. Things may get worse, frankly, when the special stimulus money runs out at the end of July. Next slide. One group has been relatively immune to the problems in the economy, and that's large health insurers. They're doing just fine in the face of COVID-19, in the face of massive illness, and in the face of millions of Americans losing their job-related health insurance. In fact, the industry, according to our estimates, says the Vice President of Moody's could have a net benefit. Next slide. If we look at the first quarter profits, so these include the month of March in 2020. In fact, first quarter profits for the major health insurers were actually up. Next slide. And if we look at the what the market thinks is going on with health insurers, health insurance stocks are near an all-time high. So apparently Wall Street does think their future is rosy, and the green line is the Standard & Poor, which is not doing nearly so well. Next slide. Now, let's talk a little about what COVID has done to doctors and hospitals, nursing homes, other aspects of the actual delivery system. Next slide. Many doctors' offices are simply can't make payroll, having to be shuttered, and it turns out to stay afloat in the pandemic. Many doctors' offices have turned to GoFundMe campaigns just to pay their staff and keep their doors open. Next slide. And if we look at employment between March and May, so up to the middle of last month, there were huge losses in ambulatory services, including doctors' offices, large losses in home care, nursing homes, and even within the hospital sector, there has been a 3% decrease in total employment as people get laid off and demand has shrunken. However, health insurers seem to be doing just fine in terms of their employment. So we have seen health insurers take this opportunity to play a larger and larger role and make more and more in the way of profits in the face of a pandemic. Next slide. Meanwhile, many of our health workers are living in poverty. A large percentage of hospital, nursing home, and particularly home care workers were living in poverty even before the COVID pandemic. Next slide. And next slide. And even before the pandemic, many of these frontline healthcare workers were themselves uninsured, including about 15% of all home care workers in this country. Next slide. Okay, now what's going on with the healthcare system? How can we get in the middle of the pandemic, people losing their jobs in healthcare, health insurance companies making it like bandits? And I want to just go back to this book by Regina Hertzlinger called Market-Driven Healthcare. And for those of you not in the field, she popularized the idea that hospitals would turn into focused factories that would pursue profitable service lines one by one. And while the book was a somewhat exaggerated view of where we were going, it does actually give us some insight into what's wrong with the healthcare system and why it's doing such a terrible job fighting COVID-19. Next slide. For instance, elective surgeries, one of these profitable service lines that Hertzlinger recommended, are the cornerstone of our hospital system's operating model. And the negative impact due to the cancellation of these procedures cannot be overstated. So this is actually a quote from the owner of the largest for-profit hospital firm, which at the time was laying off medical assistants who were involved in COVID-19 testing. So at the same time that demand for care, for sick care was increasing, the hospitals were seeing their business model shrink and collapse. Next slide. And a consequence of that is that hospitals that don't provide tons of elective surgeries, that actually serve communities in need, find themselves in a poor financial position. And this is actually data purchased, like this data released within the last week on the total value of buildings equipment at U.S. hospitals, the total value of capital assets, if you will, per bed day at U.S. hospitals. And hospitals, total assets are in green, but hospitals that serve lots of Black patients, lots of Latinx patients, have lower assets to lower value buildings and equipment to actually provide care to their patients compared to hospitals that serve mostly white patients. Next slide. And of course, these Black and Latinx serving hospitals are able to offer fewer high-tech services. These are odds ratios that a service will be offered at a Black or Latinx serving hospital relative to what is offered at a white serving hospital in this country. So we have starved many of our hospitals, particularly hospitals that pay for poor people and for people of color. Next slide. Of course, as many of you know, we've seen tremendous bureaucratization and growth of administrators within the healthcare system, designing these focused factory models, collecting from hundreds of or even thousands of insurance plans. Next slide. And at Duke Medical Center, for instance, they have fewer than 1,000 beds, and yet they have 1,600 billing clerks, jobs that really should be, and personnel who really should be retrained for patient care. And perhaps we can talk about a just transition at the end of this, but if we are going to expand primary care, mental health care, substance abuse care, if we're going to upgrade the hospitals that are used by people of color, we're going to have lots of new jobs within the healthcare system so we can retrain some of these people displaced as we shrink the administrative side of healthcare and actually use those people to enhance care for the population. Next. Okay. Overall administrative costs in the US versus Canada are obviously massive, but in the setting, these are on a per capita basis. We're spending about $3,000 more per capita per year in healthcare administration. That's relative to Canada, and that's $3,000 that's not actually available for patient care. Next slide. So what has happened in terms of COVID-19? Well, Congress has done some things. They've established free coronavirus testing. Some insurers, but not all, will waive your deductibles and co-payments for in-network treatment. But if you're out of network, you're out of luck. There have been modest extra federal Medicaid dollars to state through the Medicaid match. There has been extra Medicare dollars to hospitals, but the way they were targeted is they went to the most profitable hospitals primarily. Congress has mandated 2 weeks of sick pay, but big employers, that means any employer with more than 499 employees is exempt, okay? There's been a $600 boost to unemployment checks, which has been extremely helpful to people, extremely helpful, and is part of the reason why the standard of living of many working class Americans has not totally collapsed. However, this $600 boost to unemployment checks expires at the end of July, and I think we will be seeing lots of economic collapse, evictions, and the like. There's been massive bailout funds that went predominantly to corporations, somewhat less to small businesses, and about $1,200 per worker stimulus checks to lower paid people. So these checks, Trump insisted that he had to sign the checks himself. And next slide. And of course, sometimes there's confusion because he has been responsible for so many deaths and death certificates, and perhaps his signature needs to be on those as well. Okay, I'm done. So let me unscreen. Maybe you need to unscreen share there, Will.
Yep, that's on me.
Yeah.
All right. Thank you so much, Dr. Woolhandler, for that great and really kind of gripping and frankly frightening presentation on some of the effects of this pandemic on patients who are most vulnerable. It reminds me of Julian Tudor-Hart's inverse care law that says that the communities that are most in need of investment in healthcare are often the least likely to get it. So I'm a little bit behind on checking questions because I was sharing the screen, but I have a couple that I had sort of thought of to kick us off here. And so, one of the things in this pandemic that's occurred is, this rapid, increase in the amount of information that we know day by day about COVID-19. And it seems like, we're going to have patients recovering from COVID-19 for, quite a while and experiencing significant long-term effects from their illness. But as you pointed out in your presentation, many of these measures that have been introduced by federal and state legislatures to combat the pandemic and the economic consequences are sort of designed as short-term goals. And I was wondering if you could comment on that and what you see might be some of the consequences or what we might see in the coming months.
All right. Well, first, so the technical issue about long-term health consequences, certainly people who suffered strokes or heart attacks or kidney failure may have long-term consequences. Many people who had severe ARDS, severe respiratory failure, do seem like they currently have some lung abnormalities, but in other viral illnesses that induce ARDS, most of the abnormalities clear up over 6 months to a year. So we're still hopeful that the lung problems will clear up over time. We don't know that because we've never seen COVID-19 before, but I think we're hopeful about that. I'm pretty clear that the economic impacts are going to be with us for a while. We're not through the first wave of the epidemic. In fact, we're still in the first wave. We might get a second wave. it might become endemic unless we can come up with a vaccine. So the negative effects of COVID-19 are really likely to be with us for quite a while.
Right, and those, those effects are both on the health of individuals, and then also on sort of the U.S. economy, on state budget economies. And I was wondering if you could speak to sort of the fact that, for many of these, communities, Black communities, brown communities, working class communities, the gateway to medical care is through Medicaid, and Medicaid is in large part funded by states in addition to the federal government. And currently, almost every state in the United States has a requirement that they balance their budget every year. So what do you think we can expect to see coming up, or coming down the pike when the economic bill from this pandemic comes due?
Okay. The only entity that has a financial wherewithal to pay for coverage is the federal government, because the federal government can deficit spend. They can just print money if they want. And as Will is pointing out, the states are not allowed to do that because all 49 states are required by law to balance their budget. So if we're going to have the money to have the public purse, the taxpayers pick this up, it's going to have to come through the federal government. Now, even within the Trump administration, they are responsive to political pressure to come up with money to deal with this. And certainly if we have a new administration come January, I think we're going to have to demand that administration come up with the money to pay for health care. I do think the demand that some of the demands of the single payer movement are actually a whole lot stronger than they ever were before. Certainly we have the electorate on our side, and certainly many people who thought they had good private health insurance don't have it anymore. But also the whole idea that there's a price on a sick person, and that the price that you get for doing an elective surgery makes it very profitable to provide that, but the price that you get to take care of someone dying from respiratory failure makes them unprofitable and makes your hospital go under. I think that idea has kind of hit home to people, that the whole way we think about healthcare as having prices and having fees and having different insurance, that's a crazy way to provide healthcare. So I actually am optimistic. I think I'm much more optimistic than Professor Reed, frankly, that we're going to make a lot of progress in terms of universal coverage and increasing the government's role in paying for coverage. Will we get all the way to Medicare for all? Well, I sure hope so. I don't know that, but I think we're at a point in history where we can really make a lot of progress on that one.
Yeah, it's interesting you mentioned the role that perhaps voters who thought they had good health insurance but lost it during the pandemic might play in helping swing the tide of public opinion on Medicare for all and single payer healthcare. One of the really great questions that we got in the chat during your talk was about your comments on the financial health of that health insurance industry. And so the question is, how can health insurance companies be doing so well if they're collecting premiums from millions of fewer people than they were before the pandemic? If the economy has sort of bottomed out and everyone's lost their job, how are these companies still making money? What's keeping it alive?
Okay, they're making money because people are not using these elective surgeries that are so expensive and elective medical care. So everyone's has been afraid to go see the doctor, and certainly if you need elective surgery, you probably tried to prevent it and postpone it, and you're thinking about getting it later. I mean, even people who needed cancer surgery were initially postponing surgeries, but certainly people with less urgent or less emergent needs for medical care just postponed it, and many, probably some of them, are never going to end up getting that surgery, you know. So it turned out that the health insurance companies saved so much money by everybody being afraid to go in and get routine medical care that even after they paid for COVID, they were just rolling in dough and making huge profits.
So we sort of have this issue of people, you know, paying up front and then essentially being denied the ability to access that care that ostensibly they should be able to. And I wonder as well, or the person who asked the question was also wondering as well if there's perhaps a role here that investors, you know, maybe the reason why the health insurance stock is so high is that, you know, investors are forecasting an increase in premiums next year.
Well, in order to get the increase in premiums at each state, the insurance company has to go to the state regulatory board. Now, in some states, it's like a rubber stamp, but in many states, the insurance commissioner actually looks at the finances of the insurance company and makes a decision about the premiums. But it means that even if the cost were to go up, they could go to the commissioner and probably get a premium increase. I think part of it is that they've been able to use their cash to actually strengthen their position. So they've been doing things like rolling out money to the doctors and hospitals who are within their network, creating a strong incentive for doctors to come into their network to allow the insurance company to have greater control over them within the network, because the insurance company is the one doling out cash to them. So I do think they will be using their all these reserves that they have to try to strengthen their position vis-a-vis doctors and hospitals, and perhaps that's what investors see as the long-term rosy outlook for the insurance industry.
Excellent, thank you. Another one of the really great questions that we got, to circle back to some of your slides on the distribution of resources between, you know, wealthy patients, you know, hospitals that serve predominantly white communities, and hospitals that serve predominantly, you know, Black or Latinx communities. What kind of data do we have about the breakdown for hospitals that received funding under the pandemic stimulus measures passed by Congress? You know, how has that been distributed between hospitals?
Okay, the initial huge chunk of money was just pushed out to hospitals based on their total revenues the previous year. So if you were a big elite hospital that brought in an extra 20% above other hospitals on a per patient day basis in terms of revenues, and you got 20% more than those other hospitals. If you were a struggling community hospital or a public hospital that was getting much lower reimbursements per patient day, then you ended up with much less money out of the original bill. The second round was supposed to correct some of those inequities and go more toward hospital areas with high rates of COVID, like New York City and Boston. And they were supposed to give a little extra money to hospitals with high Medicaid loads. However, those second and third rounds were much smaller than the first round. So today, the money has gone predominantly to the richest hospitals in the country. So the exact opposite of where it was needed the most.
Interesting. So we're going to do one more question to you before we open it back up to questions for both you and Professor Reed. So we have, let's see here. So besides spending less on public health, we also have, you know, sort of this lack of integration between, you know, hospital care, you know, the healthcare that we get as individuals, and public health within our medical system. And you know, when we think of public health, we're thinking oftentimes of government bodies, regulatory bodies. and sort of the people who choose whether or not to fund that. And as you know, the question that we have is how do you think that we can sort of begin to address these issues, particularly, you know, thinking about the movement for Medicare for all?
Okay. Well, the first step is to recognize that this is a problem. I mean, I bet very few people on this call, other than the public health experts, knew that public health funding had come down 20% in the last decade, right? And that about 20% of the state and local health department personnel had been laid off, right? As we reduced our public health spending from more than 3% of health spending to 2.5%. So that's part of the problem. I mean, the public health people in general, yeah, I work in public health now. I worked for many years as a clinician in internal medicine, but those are usually the good guys. You know, they're actually people trying to do their job, but it's very demoralizing when 20% of your colleagues get laid off and they don't even appoint, you know, the head political administrator in Washington who's supposed to help you out. And they allow 700 positions at the CDC to go unfilled. It's very demoralizing and has made it very hard for our public health workforce to do their job. So we need a president, hopefully a new president, who commits to funding public health. We need Congress to commit to that. And we as physicians need to support that. I think part of what you see in countries like Canada is that, you know, since the government's funding the entire bill for public health and medical care, they can make the decision about what's the most efficient use for those dollars. And if they decide that we need to give more money to public health and less money to, say, shoulder replacements, which by the way don't work very well, but occasionally they work, right? But they decide we need the money more in public health, they can do that. And that's what's happened in Canada. But the United States, we have a market-based system. We have neoliberalism that tells us the public sector can't do anything. It's all got to be done privately. And consequently, the money has just been going and going and going into hospitals, into for-profit insurance companies. It's been going for services that are profitable, but not necessarily that are most needed. And that just left us with going into the COVID pandemic with a substandard healthcare system and a substandard public health system, despite spending more than any other nation on earth on health.
Thank you so much. I think that's actually a terrific segue to pivot back to sort of our open Q&A session for both you and Professor Reed, you know, especially thinking about what he said about a politics of sort of like public benefit, right? And this idea that we need to conduct business in this country or governance in this country with an eye towards actually helping people. So I'll turn it back over to my co-moderator, Martha, who's going to do the question wrangling for this last part of the Q&A. Thank you again, Dr. Woolhandler.
So, hi again, everybody. I'm going to start out with a comment that was put in the Q&A by one of our attendees, and it's directed to you, Dr. Woolhandler, and it's probably somebody you know, because they say, Steffi, perhaps you and Bernie could make a series of these kinds of presentations as part of preparing for the Democratic Convention, so we can raise consciousness on these issues in time to influence the Democratic platform and maybe help to nudge Biden and his VP nominee. Is this possible? And this goes right along with another comment that says the current nominee is not a strong proponent and is willing to compromise and compromise. Can we get this done? So that comment was for you, Steffi. So you might want to start out answering that, and then both panelists maybe talk about how we can kick a little butt at the Democratic Convention and before to get the best possible platform plank on our issue.
Okay, well, I should be clear, you know, the Bernie and his staff call me from time to time with a health policy question. They do not ask me for my political strategy advice, okay? So I agree with the questioner that this would be great to have a real strong Medicare for All statement at the convention. My guess is that's going to happen, but you know, I don't have an inside track on that.
I think the intent of the person making the statement was rather for you to provide more of your data to the Bernie folks in particular, not for you necessarily to be advising on strategy. But as we know, your data over the years have been fantastic aids to moving forward. And that,
okay, well,
I think, is the intent of the questioner.
Okay, well, thanks for the suggestion. I think I'll send it along. Okay.
Okay, Dr. Reed, on that question about any thoughts about how we can move our piece of this platform in the coming couple of months, or the month or two. Yeah.
Well, I mean, I know that we're going to have some voices on the platform committee. I mean, I don't know. I mean, look, I think that we need to do whatever it is, or more whatever it is we've been doing, like pressing for the Jayapal Sanders bill in Congress as a short-term proviso. Like I had a little bit of an end to the joint Biden-Sanders task forces, but I'm not sure what the state of the healthcare task force is. Like I know we're going to have some people on the platform committee. I mean, I suspect that there'll, you know, be another fight at the platform committee meetings like there was in 2016, and maybe another fight on the convention floor. I know that the line is going to be that we have to unify and not show any dissension, because that's been all Biden's had to offer so far. So I mean, I don't know. Like we're not in a strong position, and I mean, my will has the optimism that Steffi has. Practically, I mean, I hope she's right, and I hope I'm wrong, and she probably knows better, has a better feeling for the pulse of the national debate around healthcare. I just, my sense is just that Biden's not really prepared to give anything up. I mean, we've got to push as hard as we can to see what we can get, but yeah, that's my hunch.
I'm just seeing a comment from our old comrade Anne Emanuel Byrne, who urges us not always to use Canada as our comparator, but rather to look at maybe some more aspirational comparators, one of which is represented by the photograph that's behind Dr. Reed, that is Cuba.
Yep.
Now, when we do health policy, we usually talk about comparing like with like, rich systems to other rich systems, but frankly, my dears, Dr. Byrne is absolutely right. Cuba and Costa Rica have us beat by a mile. Mm-hmm. So I think that where we really should go from here is to have Drs. Woolhandler and Reed each give us a sense of where you see us going as a movement within a broader social movement in the next couple of months.
Well, I've just seen tremendous movement within the medical community with major medical student involvement through White Coats for Black Lives, demonstrations around the country at medical schools, in some cases committing to change the way they think about recruiting and admitting Black people and other people of color, to try to actually start to approach parity of minorities within the profession, parity with their share of the population, in ways that I have never seen that in my lifetime. you know, and I've been around a while. So the medical journals have been carrying articles and opinion pieces and data about racism, about transforming the healthcare system, about critical of employer-sponsored coverage in a way that I've never seen it in my lifetime. So certainly within the House of Medicine, if you will, we're seeing a tectonic shift in attitudes towards social change. And that is a lot our job, right? We tend to work in the healthcare system primarily in this organization. So we need to be out there leading that, pushing it, providing the ideas, working within our hospitals or departments to actually get some change, not just symbolic stuff, what my kids would call performative anti-racism. We don't need to just perform our anti-racism. We need to do our anti-racism to actually use this moment to get some changes in the healthcare system, and particularly within the medical profession.
Dr. Reed?
Well, that sounds pretty encouraging to me. I mean, it's good to know. I mean, I've been saying lately that, you know, I'm not even 100% convinced that there's going to be an election in November, right? So I think I set the bar pretty low. I don't know. I mean, it's great to learn that these openings have occurred, right, and have been forced by the moment. And I certainly agree with Steffie that you know, our job is to take advantage of them and to pry them further open. And next couple of months, I mean, I don't know. I mean, I think the political situation overall is very fluid. I think, as I've said before, I think the moment should be ripe for propagating support for Medicare for all broadly and beyond that. I think, you know, that's the challenge that there is for us. You know, I often say that I'm a political scientist, and as a political scientist, we work best at predicting what's already happened. So I could tell you why it was necessary that Woodrow Wilson won the presidential election in 1912, but when it comes to looking down the road, we're not so successful.
Well, that's true of us as doctors too, you know. We're not so good at predicting the future either for our patients.
Right.
Okay.
So I guess, I mean, we'll see, but it depends on our efforts, partly.